So again, thank you for joining us. As I said a second ago, this is our 8th session that we've done this, and this one we're looking specifically at vaccines and what happens when a COVID vaccine comes out. How do we communicate that? What are some of the challenges that we're going to have? Before I get started, I just want to mention that next week is the last session that we'll be doing, at least for the summer. And that'll be with Deanne Brisebois from the Retail Council of Canada. And much like we talked to Dr. Jacques Nattel in the early days about what do we do at the beginning of COVID, and how do we talk to retailers and how do retailers talk to their customers, now we're going to be talking about what do retailers do when they're starting to reopen. And they have a whole new set of rules, rules of engagement, I guess, in terms of what people can do in their stores and how do we go. So we'll be discussing that next week with Deanne. This week, let me introduce Dr. Noni Mcdonald. She is a professor of pediatrics at Dalhousie University and the IWK Health Center in Halifax. Noni's major areas of interest are vaccines, including vaccine safety, hesitancy, demand, pain mitigation, education, and policy, especially through her work with the World Health Organization. She has been a member of the Strategic Advisory Group of Experts on Immunization for WHO since 2017, and she also chairs the WHO Decade of Vaccine Assessment Committee that has been charged with reviewing the progress, or not, as she says, on the Global Vaccine Action Plan. And this will be presented at the World Health Assembly in 2020. Dr. McDonald has published over 400, I hear almost 450 papers, was the founding editor of the founding editor-in-chief of Pediatrics and Child Health for over 20 years, a former editor-in-chief of the Canadian Medical Association Journal, and has been recognized in Canada and internationally as an advocate for children and youth health, and as a leader in pediatric infectious diseases and global health. She is an officer of the Order of Canada and a recipient of the Order of Nova Scotia, and I am very pleased to have you here talking with us today. Thank you for joining us, Dr. McDonald.
Thank you, David, and thank you for the kind introduction.
Well, it's I was almost out of breath. It's quite the it's quite the prestigious introduction. So I want to make sure people know who we're talking with today. Just very quickly, Leger has done a quick look at vaccinations and some research that we just published this week. Basically, we asked people, did they have the influenza vaccination last year, which is the far left of this slide. The red line is Canada, the blue line is people in the United States. We asked people what their intent was for this year. So intent for next year coming up is a little bit higher than what we saw in the past year. And we also asked people, do you plan to get the COVID-19 vaccination when it becomes available? So about 61% of Canadians and 52% of Americans expect to get the COVID vaccination, which I find interesting because more Americans say they got the influenza vaccination than Canadians last year. So some subtleties of difference there. And then when I look at different age groups, you know, it's clear that the older you are, the more likely you are to get vaccinated, the more likely you are to plan to get vaccinated, and the same thing with COVID to a certain degree, although there's a bit of a skew of 35 to 54-year-olds being the lowest group. So this data in mind, Dr. McDonald, what do you think when you see this type of data? How are we set for the COVID vaccine when I see that 61% of Canadians feel that they are likely to get that?
That's the good news and the bad news, okay? Because COVID-19 was brand new to the world, it had not been here before, it meant there was nobody out there that was protected from this because of natural infection in the past, okay? And when you look at how this microbe is spread and what the reproductive rate is, it suggests that we're going to need somewhere between probably 60 to 80% of the entire world immunized and protected before we're going to be able to be all protected. Okay. So that 61% of Canadians are thinking about it is good. It's probably not enough. And we do know that for all of the polls, you don't get every range of people that answer polls. So overall, it's probably a lesser number than that.
Well, yeah, intent doesn't always mean that it actually
Yeah.
happened. Definitely, that's true.
The
Yeah.
interesting thing in the poll is, and not surprising, because people know in Canada that most of the deaths have occurred in seniors, particularly those in long-term care. So I'm not surprised to see that 78% of those over 65 said, I want this, I'm going to do this. But what is fascinating is that in the younger age groups, 18 to 34, 57%, 35 to 54, 53%. That's not great. And what they forget is we've got people in those age groups who've died, all right? And we also know that no vaccine is 100% effective. Never is. We don't, no drug's 100% effective, okay? So what we need is community protection, which means we've got a large enough part of the population immunized to protect those, say, 10% who got immunized who were not protected because it didn't work for them, and those who are unable to accept that immunization. They've got an underlying disease, which means they don't respond to the vaccine at all, or they're immunocompromised, they've got cancer or something else that means they're at risk by whatever vaccine that they chose. And this is going to be a very complicated issue to transmit to the general public in terms of communications. But you know what? Hey, I didn't think a year ago that people would have any clue what flattening the curve meant or what an R naught was. Okay, yeah. You know, the number of recombinations that you need, the number of people you need to contact to keep an epidemic going. I don't think anybody outside of epidemiologists would ever understand those things. And now we've got large parts of the general population getting it. So they should be able to get some of the complexity that's involved here. So let me outline some of the things that we're concerned about in terms of communications. You know, when I talk about influenza vaccine, as you asked in your questions here, it's one kind of influenza vaccine predominantly. It's the killed trivalent influenza vaccine. So when I ask you the question about influenza vaccine, you answer it based on the influenza vaccine as you know it in the general public. That's not what it's going to be looking like for COVID-19. At the present time, there are 7 different types of platforms that their research is going on and or trials have started for COVID-19 vaccine. They are all across the map. We've got killed vaccine, we've got inactivated vaccine, we've got mRNA vaccines, we've got DNA vaccines, we've got vector vaccines, and on to have 7 different types. And this means, David, and this is why it gets complicated, is each of those will not likely have the same vaccine schedule. Some you may need 1 dose, some you may need 2 doses. They may last a different length of time when you've had it. So this one may protect you for a year, but this one's going to protect you for 5, okay? All different kinds of stuff. They may have different safety profiles in terms of what the side effects for the vaccines are. They may have different effectiveness in different age groups. This one may be really good if you're over 65, but this one doesn't work so well if you're over 65. And if you're over 65, this one only works for 6 months. Where if you're 35 and you get it, it works for quite a bit longer period of time. That complexity, David, has to all be explained. And then we've already got anti-vaccine groups out in the US saying, oh, you don't want COVID vaccine. That's why it's not a surprise to me around the COVID vaccine one. Because you know what? They used embryos from abortions for that vaccine. You don't want to support abortion. And what they failed to tell us in that is this is a typical anti-vaccine maneuver. They were very selective in the information they presented to you. Okay.
Yeah. So how do governments, how do health professionals, how do people start talking about this? Because it sounds to me like everything you start to talk on, it's very easy to discount if I'm an anti-vaxxer. Because I select a piece of it and go with that, or I select one aspect of it and blow that up. How do health professionals start to communicate when the vaccines are ready that this is something you should get, and that 61% should go to 80%?
So a couple of things that we do know, and we should be doing this now long before this comes out, because this is true for all different kinds. We know that when people are trying to present disinformation, that's the fake news stuff, all right? They use 5 particular techniques and they use them over and over. And although I don't like to be big P political, just listen to Donald Trump and watch what he's doing right now, because he uses these 5 techniques over and over again. One is conspiracy. Government's out to get you. Immunization programs out to get you. Somebody's out to get you, okay, in quotation marks, when that's not true at all. Selectivity, and we'll come back to the abortion piece in a minute. Let me just pick that one little piece out for you, out of context, without all the information that you know to understand that piece, and now I'm scaring you, okay? Misrepresentation and false logic. After it, therefore, because of it, you know, that whole thing. Fake experts. Listen, do you want to listen to Donald Trump when he recommends that you ingest a disinfectant when it's got a skull and crossbones on the outside of it? He's no physician. He's no healthcare provider. Why would you listen to healthcare from him? Okay. And then they want, whatever it is, whether it's a drug or a vaccine, they want it to be, they have unrealistic expectation. They want it to be 100% safe and 100% effective. Gee whiz, David, getting out of bed is not 100% safe. Okay, you might fall and skid on your sock and hit your head. Okay, we have nothing that's 100% safe and effective. So they use these techniques over and over. And what's been shown is, if I teach you those techniques and I tell you to watch for them, you become much, much smarter about what you listen to and what you take in, because you start to see those people using those techniques. And then your brain goes, I need to wait on this. I need to really verify if that's correct or not, as opposed to just taking it in and saying, oh yeah, that must be the truth. So let me go back to the abortion piece. So that was selectivity. You shouldn't get a COVID-19 vaccine because it comes from abortions. Well, the tissue culture that's used for one of the 7 different types, not all of them, one of the 7 different types is grown in cells that came from embryos. They came from one embryo that the mother electively decided to have an abortion more than 50 years ago, not to have those cells selected to become tissue culture. She made that decision totally unrelated. It was going ahead whether that tissue culture evolved out of it or not.
Yeah.
Kind of a different perception around abortion there, right? In terms of the vaccine. And then that went on to be immortalized into this tissue culture line. So it's quite, and we've got 6 other kinds of vaccine out there that are being developed that have nothing to do with that cell line at all.
But they just focus on the one.
They took
and that
selectively
one tiny piece of it. Yeah.
And they smeared it all. Okay. So one
Yeah.
of the pieces that I would talk about now that I think we really, because there is so much disinformation coming out of you. It's a cascade of disinformation about all different parts of COVID-19 pandemic, but in so much the rest of your life. We need to be teaching everybody about these techniques that they use so that you can start protecting yourself against these techniques. So, you know, as soon as somebody says something like that, like this whole abortion thing, it should have been, tell me the whole evidence here. I want to know more about this story before I make a decision. And then that's where you get the rest of the story coming out.
So this is getting a little bit away from vaccines, but it's all related. Do you feel that our schools should be teaching children on how to read media, how to read news in a bigger way? I'm starting to see some high school classes start to touch on this, but would that be something you'd advocate for?
Absolutely. I've been advocating for this for over a dozen years, long before COVID-19. Okay.
Right.
And we're very fortunate in Canada for a couple of things that already happened, David. One is the British Columbia Centre for Disease Control, who I don't know how many years ago now, must be half a dozen years ago at least, started a program called iboostimmunity.com. And we as adults can go in and do quizzes about immunization. And when you get the quizzes correct, they donate a dose of vaccine to UNICEF. They then did a kids version for it called kidsboostimmunity.com. It's free. And when the kids get the quizzes right, then a dose gets donated to, a vaccine gets donated to UNICEF. And what's very cool about this is the Public Health Agency of Canada has taken the kidsboostimmunity.com one and they have translated it into French. so you can be Francophone or Anglophone to use it. It's used in a number of schools across Canada, including some schools here in Nova Scotia. The kids really do learn about immunization, and they learn what's true and what's not. And the other thing that Kids Boost Immunity has put in it is cognitive thinking. Okay, so just the stuff we were talking about. So the kids are already learning about those techniques. Now, I would like to see beyond Kids Boost Immunity. I would love to see the curriculums across the country really build into them media savvy, how you get conned by fake news and disinformation, because we need the next generation of kids to be growing up so they really understand what science is, how science changes over time, and what disinformation is, and what pseudoscience is, and how people are trying to sell you junk, okay, and make you believe stuff that's not true. So, you know, if we'd done this really well, everybody should have raised their eyebrows when Trump came on with saying ingest disinfectants, because they should have said fake expert, okay? What, you know, they should have automatically asked those questions before they jumped to follow them. And, you know, sadly, the calls to poison control centers in the US went up after he said that, for exactly people who are trying to do something dumb with some of these disinfectants.
With some of these things. So, but these tactics, these 5 points, techniques of false news, fake news, are working. Because now you're starting to see measles flare-ups. You're starting to see increased percentage of Canadians, Americans, globally, people not having children vaccinated. Are you concerned about, do you think we can turn the corner, make you turn back and get back to increasing, or are we down a really dangerous path right now?
You know, I wish that was an easy question, David. It's not. A couple of things that have happened right now because of COVID-19. We know in Canada that we have a growing number of kids since the pandemic came who have not received their routine immunization as an infant or a child because their mother was too afraid to take the kid to get immunized, or
because we were supposed to be social isolated.
Exactly. And the system wasn't set up so that they could feel they were doing this safely. So we're in a catch-up position now, and this is true in almost every country in the world. There are huge numbers that WHO has estimated of kids that are not fully immunized now compared to where we were even a year ago. It's pathetic. And so we're going to have to do catch up. So again, we're going to have to communicate about that and say, you've got to get caught up, because if we have too many kids not immunized, we're ripe for a measles outbreak. And, you know, people think that measles, well, we're so much better than we were 30, 40, 50 years ago, and nobody dies from this. David, same number of kids die now as they did 50 years ago. 1 in 1,000 kids who get measles die.
Wow.
It's done.
Okay. Yeah. Well, and that's so beyond immunizations. Our healthcare team at Leger did a real look at people with chronic conditions in Canada and how they've been accessing the healthcare system since COVID, and appointments are down. Filling prescriptions are down. People are now hoarding their medications or taking less medication to try to make it last longer so that they don't have to go get more. So there's big changes across all of our health when it comes to how COVID's impacted us.
So one of the communications pieces that I'm really interested in seeing much more coming out on is we are never going back to where we were. It's not going to happen. Or if it does, it's going to be a different way than what we were before. And we're not going to have COVID all controlled globally for quite a long period of time.
Yeah.
All right. So that means we need to figure out how people can keep themselves healthy, keep their family healthy, and keep their community healthy. And what can you do to do those things? And for those with chronic diseases, if you're not healthy with your chronic diseases, you're probably going to end up in the healthcare system using it. And we may need that part of the system for the next wave of COVID to deal with it. Okay, so we want you with chronic diseases to be as healthy as you can be with your chronic disease. So we have to figure out, as part of the system, but also you as the user, how to get you back together in a safe and good way. Yeah. And that's where we haven't had enough conversation, and we've not been listening well enough. So some of the mothers didn't come, or parents didn't come forward with their babies because they didn't think it was safe. Some of the clinics made it really hard for you to come because they cut their hours. Okay, they made access a real problem. Okay, and some of them, there was no information out there that people, it got lost in the storm of information that came. So people didn't know that you should be still immunizing, and people didn't know how to go about doing it. So it's not simple, the solutions to these things, but boy, do we need to start talking about it.
Yeah, definitely. So let me, just for anyone who's online right now and listening in, there is a questions bar on the right hand of your screen. If you'd like to type in a question, I am happy to share it with Dr. McDonald as we go through here. So we have opposition. The 7 COVID vaccines start to come out. Regardless of whatever we say or health professionals say, there's going to be opposition to this. So what do we say? What are some of the key messages from your experience, like that help to address these negatives, but also what are some of the positives that we need to be talking about that people really listen to?
So a couple of things that we know for sure. Stories are way more powerful than facts and data because a story sticks, okay? We are in evolution as humans, as oral people. We share our stories, all right? And they are very powerful. So we need stories about the people who've died. We need stories about that 18-year-old who died, that 34-year-old who died, and that they were perfectly healthy before this. And we need those stories to be told.
Yeah.
Second piece we know is we don't like negatives, okay? So if I tell you this vaccine is 0.1% risk of an adverse event, you will hear that 3 times louder and it'll stick and you will have negative feelings about it. Whereas if I frame this as it's 99.9% safe, you don't have the same negative piece about that. Why do you think some of the people who advertise products focus on the good stuff in it? Do you want to eat hamburger that's 25% fat or 75% lean?
Lean. Yeah,
Okay,
exactly. Yeah, that's a good
it's
point.
the same hamburger, okay?
Yeah.
So we need to be thinking about how we're framing what we're talking about. We also need to be presenting truth, you know? We need to say what the science knows, what it doesn't know, and how we're going about to find out the science that we don't know, okay? None of this waffle babble stuff, okay? We need to be very truthful about what we're doing. We know for people to trust healthcare professionals, trust the immunization program, trust the system. It's got 2 components to it. One of them is, how competent are you? What's the science here? What do we know? And the second component is, I need to show compassion. Do I care for you? Does it sound like I really am worried about you? So I'm going to use a slight analogy here. I think probably everybody listening here knows Bonnie Henry from British Columbia, who's the Chief Medical Officer of Health. And many of you will have seen her almost in tears when she announced the first deaths in the long-term care facility. She didn't prescribe and do this because she wanted to do this. She is a compassionate healthcare worker. And you knew that, okay? Yeah. I'm not saying every healthcare worker should cry, okay? That's not what I'm saying. But I have to be able to show you, David, that I care about you, and I care about your family, and I care about your community, and together we're going to make the best decisions here, okay? So that has to come through. And then some of the other things that we know are critically important, what the healthcare worker actually says very much influences whether you choose or do not choose to have an immunization. So we need our healthcare workers really educated about the complexity that there's going to be about the range of vaccines that are going to be out there and how they're going to be available. And then one of the other things that's going to happen, David, I had to chuckle when I saw survey questions going out to say, do you think COVID-19 vaccine should be mandated? And I'm going, whoa, wrong question. I wish COVID-19 vaccine could be mandated because that means we've got enough vaccine that everybody could have it. It's not how it's going to happen. Not at all, at all, at all. Okay. It's going to be a scarce commodity, and we're going to have to accept how people are accepting or not accepting in the different groups. So First group out probably going to be recommended for it are healthcare workers. And then maybe if the vaccine works well in those over, I don't know, 65, 75 or whatever. But if you're line up, David, and you're over 75 and you say, I don't think I want it, you'll be at the back of the line when you change your mind.
Oh yeah,
You know,
so
because we won't have
if you say
enough.
right now, I'm not ready, and then I lose my spot or wherever it is, good luck getting it is what you're saying.
Exactly, exactly. So it's a different kind of conversation than we've had in the past, where access has not been the issue. But let me give you a little example of that. A couple of years ago here in Nova Scotia, like many of the provinces, you can get influenza vaccine in the pharmacies, and the pharmacies were doing a really good job of encouraging people to get immunized, and our rates went up and so on and so forth. Well, Nova Scotia ran out of that flu vaccine. All right. So it became, and everybody wanted more. Okay. So we were able to get in more, but not as much as what we probably could have used. So I think people need to understand that there's going to be a scarcity piece around this as well. And that's going to have to be well managed to say that people that are getting it are the people we need most to be getting it in our community to help us stay safe. Okay. So we don't want, and I'm going to be very crude and rude here, we don't want a professional football team or a professional hockey team lining up before the healthcare workers get it, just because they have more money and can pay for it.
But you don't think there's going to be some of that to a certain degree?
Oh, I think there will. But I want the community to say, yeah, because that's not helping us to stay safe.
Yeah.
And the other thing that I think is going to happen is what was never understood, David, in all the time we've been doing immunization, except maybe at the beginning with polio vaccine. I don't think people understood that we all need to be immunized to keep all of us safe, okay? So if you have half your community not doing social isolation and coughing all over everybody and not washing their hands during this COVID-19 pandemic, they're putting everybody else at risk, okay? That's why we all needed to go into lockdown. That's why we all needed to do these things. That was never understood before, and it's the same thing here. So those who get immunized still need to be doing what they need to do to keep safe, and the rest of us need to be continuing with our social distancing, continuing with our hand washing, continuing with not coughing all over everybody. And you know, I'm hoping that's going to help people understand about the importance of the other immunizations too, because it's the same reasons.
Well, because that led to one of the questions that we've received. Do you think that given people have responded fairly well to social isolation, 2-meter distancing. In general, we've done a good job of it and people have understood it. Can we use that learning and adjust it to the learning of this is why you also need to get immunizations? Yes. Can that bridge start to happen, do you think?
Yeah, well, it's interesting because I was on a WHO call this morning talking about this. And yes, I think there is the opportunity to do that bridging because people understood that you can't just keep yourself healthy all by yourself, that it is the community you live in. And what we want is for everybody to be healthy because that's the only way we can do it. So for this one, we need everybody immunized. Like, I can't remember what the number is. There's 7.6 billion people in the world, some huge billion number, okay? Well, until we get a substantive number of people immunized, and by substantive, I'm talking 60, 70, 80% of the world, Joe, I think that's gonna happen very quickly, okay? It's still gonna be a risk for all of us. And I had a Wiseacre person say to me yesterday, well, when I've got my vaccine, I'm protected, I don't have to worry. And I said, whoa, wait a second. How do you know that vaccine worked for you? How long is it going to last?
Yeah.
How do you know that you're not still at risk? And the only thing you're going to be able to do is to keep all the things that we need to do to stay healthy. Once I know 80% of my community's been immunized, we're fine because we're protecting those other people and that didn't respond well to the vaccine and those who couldn't be immunized. Okay. But that's going to take a long time.
I have another question. You talk about how stories are the best vehicle to talk about this. Who should be telling those stories? So if I'm on the fence of should I get vaccinated or not, who should be talking to me and I'm most likely to listen when it comes time for this to happen? Which
Okay, well, there's been some research actually done on that. I always like to talk to science, okay?
Yeah.
And healthcare workers telling their own stories, David, are very powerful. So let me give you a quick one on this. I remember very well standing at the bedside in the ICU of a children's hospital with a mother with a baby who had Haemophilus influenza B meningitis who was now deaf. And that mother had chosen not to immunize her child. I'm not going to go into the specifics, but had chosen. She turns to me as an infectious disease specialist with just crying like you wouldn't believe. And she said, "The disease caused the deafness, didn't it?" And I said, "Yes, it did." And she said, "If my child had been immunized, this wouldn't have happened." And what I said back to her was, "You're right, but we have to go forward now and do the best we can for your daughter. We can't go back." And she said, "But I can tell others, can't I, about why this needs to be done." So David, are you going to remember that story? It's truth.
Yeah, no, I definitely, there's no way I will not remember that story.
All right, so healthcare worker stories are incredibly important, but that mother was powerful in that community when she went to tell the story herself.
Yeah.
You know, so those two pieces need to be done. What doesn't work well is putting together a whole bunch of little clinical vignettes that have been made up that aren't truth. They're correct, but they don't have the ring of sincerity of the real world in them.
Okay. I mean, someone like Dr. Bonnie Henry would also be a great resource, I think, for something. That was the,
Exactly.
our public health professionals great for this? Okay, so going, because there's been a certain amount of prestige built up during this at this point in time.
Exactly. And people want to listen to people that they trust, and they want to hear those stories. I could go on and on. I mean, I actually looked after a little girl who had tetanus, and people are going to say, "Tetanus? You never see tetanus." You do. And David, on that one, most people don't know, including some healthcare providers, you actually need 3 doses of tetanus before you're protected. 1 dose won't protect you at all. 2nd dose, very short-lived protection. 3rd dose gives you protection. And this child who came in with tetanus had 1 dose of tetanus vaccine, not enough.
Yeah. Well, and that's to your point about COVID. Some of these vaccines might be multi-dose.
Exactly.
Before we get to the end of it. So that knowledge and understanding of which, so the very specific question for someone is, how do I know which one to choose, or will I even have a choice?
I love the question. And my answer is, sheesh, I hope you get a choice. But the truth and reality is, because I want a choice too, the truth and reality is we probably won't have that much choice. But let me reframe that into a really evidence-based science piece. We have the National Advisory Committee on Immunization. They will be, which provides recommendations for all of Canada, and then the provinces and territories have their own little committees that decide what they're going to do from there. They will make recommendations on the COVID-19 vaccines that are available in Canada. They will look carefully at the evidence. They will look at the safety. They will look at the effectiveness. They will look at the dosing schedule that's needed. They will look at how long it lasts, all of those things. And then they will make a recommendation, okay? And what we want as individuals is that our province then rolls out the best they can with what they've got based on those recommendations, right? And then we do the best we can. So it may be, David, that you're initially immunized with this one that needs 2 doses, okay? And it lasts a year. And then we get a new other vaccine that comes in that, oh my goodness, it lasts much longer. And it's in time for when your 2nd dose is, and we know you can change from one to the other if the science is there. And then they'll say, "No, David, you should get this other one because it's going to last, okay, much longer for you." So I think what we need to be teaching people is they need to listen to what NACI says, and they need to be following along, because we're going to mini-max. We're going to get the maximum benefit with the minimum amount of vaccine that we're going to have. And that's what we all need.
Okay. I have a question which is a little on the outside specific to vaccines, but what can we do as communicators beyond stories to keep people feeling psychologically positive amid sustained bad news, like
Yep.
a second, third wave, permanent impacts of COVID, etc. So how do communicators keep people feeling positive throughout this?
Yeah. I think a couple of things I want to talk about there, and again, there's some data. First of all, we know that, again, coming back to framing, if we talk about how we can go forward in a positive way, you will be much more comfortable with this and much more likely to follow. So the example I'll give you, when we had the H1N1 pandemic, Australia framed the H1N1 vaccine negatively and Sweden framed it positively. And they had more than twice the uptake of the vaccine in Sweden than they did in Australia. But the same holds true for how I tell you. So David, we've been very successful in many communities with the programs we've put in to keep us safe, okay? So when we come to the next wave, we need to say, okay, public health, what is it we need to do now? And the communications need to be framed that we were successful when we did it before. We can build on our success. We know you can do this. We can pull together. We can make this happen, as opposed to, oh my God, we're going back in again, you know, and not focus on the negative, but focus on the positive and help us move forward.
I think that's a really good point. Yeah. It's so easy to see the numbers going up every day and focus on, you know, this number of cases, this number of deaths, as opposed to this number cured, this number moved, or not, you know, this number that have no longer in trouble, that idea. So all the positive, all the good things that we've done. I like that answer. Yeah. I'm cognizant of the hour. I try to keep everyone not too long on their lunch today, but I do have one more question for you, and it goes towards, and I think this is for COVID, but I also think this is for the influenza vaccine that's going to come up this fall, which is the delivery of it. Mm-hmm. So we're hitting the fall period. You talk about parents are already not immunizing their children. Are there some recommendations for the healthcare system overall for how do people get their vaccines, especially if they're nervous about going to the doctors or the hospital or whatever it is?
So one of the things that we know that's incredibly important about every immunization where it's been looked at, ease of access makes a huge difference for how easy it is to get people immunized. Think of it for all of us. Yeah. So we will want to have influenza vaccine available in as many different ways as we can come the fall, because we want as many people immunized against influenza as possible, because that'll decrease our need in the hospital from outcomes from influenza, and allow us, if we have the second wave, to have space for the people who are going to need those hospital beds. So every time you come into any contact with the healthcare system in any way, it should be able to be immunized. So we're going to need many more public health clinics. Make it easy in your physician's office. Make it easy in the pharmacy to get it. Make it easy, maybe even going out to workplaces. You know, I was laughed at and teased when I said, when we had a mumps outbreak here in Nova Scotia among young people, and people said, how should they get immunized? They said, we need to be setting up public health booths outside the bars, because we need to go where the people are.
Where the people are.
Yeah. And we need to think about it that way, sit down and say, who are we missing here? How can we do this as best as possible?
That's fantastic. Dr. McDonald, thank you very much for your time today. Your very busy schedule, because I know you're off to another meeting in a few minutes, so I very much appreciate your time. Thank you to everyone who joined us this week, and I hope we will see some of you come next week when Deanne Brisebois from the Retail Council of Canada and I talk about opening up retail. And this talk will be downloaded and publish the recording if anyone would like to share this with other people that you think would like to hear this, especially when we talk around the whole fake news and the 5 techniques. I think that's something that people are going to take with them and share quite extensively. So again, thank you, Dr. McDonald, and everyone have a great day. Thank you. Bye now.
Bye-bye.